Hi, my name is Dr. David Houston. I'm presenting today on behalf of Professor Keith Harding, a long-time colleague and mentor, having worked together for the past decade across various projects and countries. I'd like to thank the World Union of World Healing Societies for the opportunity to talk today on the assessment and diagnostic tools as a key component for the future. Quick declarations of interest. I've got a fair history in the background of basic and translational research across diagnostics and drugs. I am the CSO of two startups. One's an advisory firm specializing in chronic wounds. The other is Transdiogen. We're a biotech company focused on precision medicine within chronic wounds using gene signatures as diagnostics. As we all know, chronic wounds pose a large and serious problem to healthcare systems across the world. The severity of this problem is shown in the 5-year mortality percentage, as shown in the bar chart. The challenge our system, patients and clinicians face is that following a chronic wound, such as a DFU, is that the outcomes are equivalent to that of all cancer. We all know that at least a quarter of DFU patients will undergo a minor or major amputation and will therefore have a 50% or greater chance of mortality within 5 years. As a system, the patient numbers and spend of chronic wounds is equivocal to that of cancer. It's therefore imperative that we have access to diagnostic tools to overcome this challenge and change the paradigm of wound care to wound healing. A recent analysis across the UK NHS by Guest et al. Over a 1-year period showed that across all wound types, diagnostic tests were carried out on average of 2% of patients. It's important to note here that this includes patients in primary, secondary and tertiary care, with regular contact with physicians across these settings. The great disconnect here is that regardless of hospital admission, the prescription of anti-inflammatories or antibiotics, there was almost no diagnostic use for wound patients, or the patient pathway, or the course of treatment. It would be unheard of in any other disease that affects so many people and has such severe consequences. But fear not, change is on the way. Recent guidelines set out by the FDA for DFU infection drug development has some choice parts that I believe are driving towards a requirement for new diagnostics. I've outlined some areas regarding the microbiology, and surprisingly, wound swabs are not generally acceptable sources for culture specimens. The sponsor must determine the bacterial isolate as pathogenic or colonizer and use this as the only determinant for the microbiological eligibility of the patients. I believe that these are outlining a scenario for the clinical trials that require the developers to develop new diagnostics or direct CDXs for their trials. Further to that, the FDA held a very interesting open workshop in, I believe it was 2022, covering many aspects of wound healing and utilizing stakeholders across the wound community. Of note, from the presenters and the representation of the regulators, I've collated their stated need for diagnostics, both within clinical trials and within the clinic, and there is a wide understanding and acceptance and need for these. A few years ago, Transdiogen, my company, questioned over 300 clinicians across 6 countries of their view on the need for diagnostics for patient stratification, similar to the PCR gene-based diagnostic used for other chronic diseases. The importance, effect to clinical practice, and acceptance was shown to be widely wanted by clinicians and how this would change their ability to treat wounds. However, there are a number of barriers to diagnostic development within wound healing that have been observed by numerous people. Large barriers include the wider perception of how wounds are treated, the limited translation of in vitro and in vivo model, all of which leads to an insufficient understanding of chronic wounds as their singular and separate diseases and as a collective umbrella term of chronic wounds. The new advancements within large data sets, large language models, machine learning, and application of AI highlights a number of issues we have faced across this field. Our current data sets are limited in their applicability for training data sets. The input requirements needed by their very nature require huge amounts of data. The output quality is always reliant on the input quality and capturing the information in a standardized manner. For utilization of AI to significantly advance in our field, this highlights the importance of wound registries, access to data, and calls for the need of new wound registries collating country, system, and population-specific data. There are current assessment and diagnostic tools that are becoming widely available. Standardization of wound measurement within one's own clinic is very doable, and there are a number of devices, some of which are shown on the right, that can all capture this type of data in a repeatable and verifiable manner. When patients are seen by multiple clinicians across different healthcare settings and at home, this is an invaluable tool to monitor and assess a patient's journey. It has changed a number of practices in their ability to record and deliver the best care for their patients. Further to that, multispectral imaging is advancing the information that clinicians are able to access in real time, providing salient information for assessing and diagnosing patients. The images shown are taken from the Mimosa multispectral imaging device, showing a localized temperature and oxygen levels, all taken by a handheld device. It does appear that multispectral imaging is the next big step in imaging diagnostics for the chronic wound clinician. Future technologies such as gene signature diagnostics, based upon the molecular differentiation of wound outcomes as a pathway diagnostic, are under development. The 14 mRNA gene signature test has been shown to stratify patients as healing under standard of care or requiring advanced wound care. This is a similar gene expression pathway diagnostic as seen in many other diseases. There are a number of developments in the areas of smart bandages, measuring numerous temporal, spatial and physiological parameters. One can see how this will change the monitoring capabilities, advancing assessments to be undertaken and reviewed away from the clinical setting. Some great work highlighted here was conducted by Professor C.T. Lim at the National University of Singapore. To finish off this presentation, I'm going to quickly run through a case study of diagnosing infection. Not only is infection such an important part of treating chronic wounds, the very nature of its treatment is part of one of the world's great health threats of antimicrobial resistance. With some shocking facts highlighted in both Nature, the World Health Organization, and the World Economic Forum, I would like to draw your attention to the fact that 4 of the top 5 most common wound isolates are in the 6 most deadly AMR pathogens. Recent research has shown that although there is a large number of wound patients treated for bacterial infections, there is still no definitive tests available. Further to this, almost 90% of wounds tested are resistant to one type of antibiotics. 30% are resistant to 6 types of antibiotics. A quick history on the diagnosis of infection. Garland's statement of laudable or good pus held for almost 1800 years and was even written up within the American Civil War. It wasn't until Pasteur, as well as others, that this theory of wound infection started to change. The graphic depicts the wound infection continuum and a number of techniques, including swabbing, bacterial counting per gram of tissue, molecular analysis, fluorescent imaging, and other biomarkers of infection have all been investigated to varying degrees of success. However, the clinical examination remains the most accurate and clinically relevant diagnostic assessment. However, recent work carried out by Dr. Serena and others showed that reliance on clinical examination leads to the misuse of antimicrobials. This, in effect, would be a driving force within antimicrobial resistance. This brings to mind a number of questions. All of our techniques and advancements to date have been flawed in various ways. The use of swabbing has widely been reported as incorrect, not specifying the causative pathogen, being highly selective towards a few pathogens, as well as other problems. Molecular biology gives far too much information, with little of it being clinically relevant. Some recent advances in fluorescent imaging has brought up a number of the same problems as that of swabbing, being that the information from the image is surface level, only a couple of bacteria can be detected through autofluorescence and thus diagnosed. A number of clinicians, AMR guardians and regulators within the UK have highlighted the possible risk posed by this type of technology. And this does beg the question that are we looking in the right location? Or are we just measuring the output of a problem located elsewhere, either inter or intracellularly? I'm finishing this talk off with some thoughts for anyone wishing to pursue diagnostic developments. We must make the data clinically relevant. That is, what, when, and how it is presented to the clinician or clinical team. The data has to tie into patient outcome or as a clinical decision making. A timely manner does not always mean right away. Very few times is there a need for an instantaneous answer, especially in chronic diseases. And I'd like to finish this with agreeing with the WHF summary. There's a great deal of progress has been made, but much work remains to be done. Let's just hope we don't fall into the trap on the cartoon. Many thanks for your time and attention. Hopefully next year I'll be there to present it in person.